Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Hello, Mrs. Holloway. It's nice to meet you here today.
Nice to see you too.
So I see here that you decided to make the appointment because of a lack of energy. Can you tell me a bit more about that?
Yes, it's awful. Over the past year and a half, I think I've become increasingly tired. I work as a solicitor, and there have been a few times now where I have fallen asleep in my office. I have had to give up my weekly game of tennis because I'm just too tired, and it is absolutely impossible for me to stay awake past 9:30 at night or wake up before 7:30 a.m. It is also quite difficult for me to concentrate when I finally do get to the office.
So you had an episode of depression about 10 years ago related to the breakup of your marriage. Are you currently experiencing any personal problems?
No, not at all.
Any other physical symptoms like being constipated?
Now that you mention it, I have been a bit constipated. Also, I have put on a bit of weight over the past year, about 6 kilograms. I think one thing I wanted to ask about is the possibility of diabetes. My brother was diagnosed with type 1 diabetes at the age of 13, and I know fatigue is a symptom of diabetes.
Let's take a look at your latest blood tests. So your glucose levels are within a normal range, so it isn't diabetes. I see that your skin is a bit dry, and it's also somewhat flaky. Is that normal for you?
Really, I've been trying to do something about it.
Okay, so fatigue is associated with quite a few possible diagnoses, but based on your lab results, which show anemia and hypercholesterolemia, which is an elevated amount of cholesterol in the blood, and a few other factors, such as your general description of how you have been feeling, the appearance of your skin, and your family history, my initial diagnosis is hypothyroidism.
Does it explain why I'm so tired, even after sleeping the whole night?
Yes, it may. Part of the reason you may be feeling tired is sleep apnea, which is often associated with hypothyroidism and may contribute to daytime sleepiness and fatigue. It can also explain the weight gain, since that is also a feature of the condition.
Is it common?
Well, it does typically present in the 5th or 6th decade, and it is 5 times more common in women than men.
And I meet both of those criteria.
Yes, depending on the cause of the condition, it may also be related to your family medical history. Your brother has an autoimmune disease, diabetes, which makes you a more likely candidate for one as well. And a common cause of hypothyroidism is autoimmune thyroiditis.
Well, what can I do about it?
Well, first, we will have to confirm the diagnosis with thyroid function tests. If hypothyroidism is confirmed, we will then need to determine the cause in order to decide on treatment.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Brownstein, how can I help you?
Hi there, Dr. Rivers. I'd just like you to do a test on my waters. I've had a few problems recently. I have to go quite a lot more, and it started to burn a little and just been a little bit uncomfortable.
I see. How long have you had these symptoms for?
Well, it's been sort of going on and off for about 3 weeks. Closer to a month, really. Some days it's better than others. I don't take too much notice. I put a lot of it down to age, but I don't think there's anything really serious, but just wondered. It seems a bit strong at the moment.
And have you had this sort of problem a lot before, or not?
Oh yes, it's happened quite often over time. Normally, just antibiotics clear it up. I'd say I've been treated for this at least 5 times in the last 10.
And you've left it for a few weeks before coming in to see me. Do you sometimes get symptoms that come and go like this?
Yes, they do, and I just try to drink more, which I'm very bad at drinking water and such like, but I try, and usually it goes well. It usually just goes off by itself, really.
Okay, and what about nighttime? How are you at night?
Oh, I'm up and down a lot. 3 times out in the night, at least every night, and it's more painful at nighttime, funnily enough. And it's much more urgent, and there seems to be a lot of pressure. I think it's been going on for such a long time, it's becoming normal.
Right? Okay, well that's not something we want you to be getting used to. Let's see what we can do. When you've had these symptoms in the past, you've had the antibiotics. Did it calm it down?
Yes, antibiotics seem to do the trick.
And what about accidents? Any accidents with the waterworks?
No, I just have to make sure I get there quickly. I find when I've been sitting for a while, once I get up, I've got to go immediately. So I always want to know where the restroom is, wherever I am.
But if you cough, sneeze, or laugh?
No, nothing like that.
So what I'm keen to do, actually, is to give you a short course of antibiotics and see how you get on. If you've had similar things in the past and antibiotics have helped, I think that the first step is to see what happens if we do the same thing.
Right? I'm not sure if this is important or not, but I had a series of water problems way back 25 years ago or so. I had a copper suspension in 1980 something. It was 50. And that worked. It worked well, I think.
Okay, let's keep that in mind. But we will start with some treatment. And if it's not improving, we'll need to reassess the bladder function a bit more closely. Are you allergic to any medications?
Yes, there are a few Septrin, Amoxil, and...
Oh, what's the other one? If you can just hold 2 seconds, I'll tell you. Keep it written down so that I can... So Septrin, Amoxil, and trimethoprim.
Trimethoprim. Glad I knew that, because that would have been my first choice. Have you had something called nitrofurantoin?
Yes, so I've been okay with that one. The nitrofurantoin, I've had it before for 5 days.
Right? So as you asked for, I will get you to provide us with a sample we can send to the lab. I think what I want you to do is drop back in and see us in 5 days, and we can review the results and discuss how the medicine is working. Okay?
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
The results of your cerebrospinal fluid investigation are back.
Or maybe my headache is still quite severe and, oh my, the light. Did you possibly close the curtain?
Yes, of course. So combined with your current symptoms, the CSF results show that you have viral meningitis.
Can you be more specific? What kind of virus are we talking about?
Well, most cases are caused by enteroviruses like poliovirus, but there are other possibilities like herpes simplex virus, mumps, and West Nile.
Well, which one do I have?
Well, this investigation doesn't tell us that. We will have to do another investigation to determine the exact virus, which will help us know exactly how to treat you. Oh, here we go.
Again, why can't...
Now look at question 26.
And Bart, can you help me out for a minute? I have this scan, and I think I'm seeing something quite rare, but I want to make sure.
Sure, let me take a look.
So do you see this right here, the downward displacement of the cerebellar tonsil? Do you think it's a Chiari malformation? But it can't be type 2, can it?
It has to be a type 1 Chiari malformation. Yes, I'm afraid so. Here you can see that the cerebellar tonsils are displaced by more than 5 millimeters through the foramen magnum. How old is this patient?
17. He was referred to me after he started experiencing headaches and balance problems.
Well, those are common for type 1. If it were type 2, he would have been diagnosed much earlier, I suppose.
Now look at question 27.
Oftentimes, when a junior surgical trainee asks what suture to use for the skin, a common response is what the boss likes. The answer has a number of purposes to maintain the status quo and to cover up the fact that many of us have only a very basic understanding of suture materials. So that's exactly what today's session is about, why different suture materials are used, and why it matters. So suture types are broadly split into the following categories: at absorbable versus non-absorbable, braided versus non-braided, and natural versus synthetic. For the first category, absorbable sutures are broken down by the body over time through processes like hydrolysis and enzymatic degradation. The amount of time required depends on the material as well as the location of insertion and the individual patient characteristics. For example, the absorption rate of sutures can increase in patients with ongoing infection, fever, or protein deficiency. Skin closures of a clean wound are mostly achieved with this type of suture, as it provides soft tissue approximation to aid the healing process without permanent implantation of foreign tissue. However, not all absorbable sutures are created equally.
Now look at question 28.
So how are things going in your first week?
All right, I guess. The patient in bed 8 just yelled at me. What can I do? It was necessary for me to do an intramuscular injection.
I know that patient. Did you check if you had a preferred injection site?
No, I didn't think to.
Do that. Well, he is receiving regular IM injections, so it's a good idea to rotate injection sites.
Yes, his deltoid was a bit bruised.
Next time, maybe use the ventrogluteal site. As far as I know, the patient should not have any problem getting into a position that would allow you to...
That site. That's great advice. I will definitely...
Now look at question 29.
What a day. I knew getting into oncology would mean I would be doing a lot of breaking bad news, and it never gets easy.
Yes, it's no easier with my patients, particularly with miscarriages.
Oh yes, I can't imagine that. It must be very difficult. No matter what I do, it always feels like I'm guessing it wrong. From the moment you start to guide the patient or family to a more private area, they know.
Yes. And there is often so much we don't know about the patient's current emotional state. We can ask some questions to make sure they are following everything, but there's so much more going on in their lives in general that we are not privy to.
And then there is the issue of patients wanting to know all of the information up front about their condition and management. But there's often a lot we still don't know.
Yes, we often know what the diagnosis is, but not the cause or other important factors that will...
Now look at question 30.
Hello, everyone. I want to start off today's briefing by reviewing some basic safety recommendations that we should be enforcing with our patients. As a few of you have witnessed, and many of you have heard about, we have had several patients have nasty falls in the last couple of days. Now, as most of our patients are post-op, it is recommended for them to get up and start moving around as soon as possible. But a few prevention measures should be taken to keep patients safe. The first is patients should wear the red hospital socks, or snug-fitting shoes or slippers with rubber soles. They should also use their usual walking aid. We should also be encouraging them to tell us if they need any assistance. We also had a couple of patients try to take walks up and down the hallway, unassisted, and it is not a good idea. Since if a patient starts to experience difficulty, they may not be able to get our attention quickly enough.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Hello, Mrs. Araceli. I am Dr. Gonzalez.
Hello, doctor. I would like to tell you something about myself. I have been married for 55 years, and we have 3 children. Our second child, who was born in 1964, had every kind of physical problem and was in the hospital for 10 months. However, we did not have a diagnosis until she was 4.5.
What was the diagnosis?
Prader-Willi syndrome. Yes, it had a severe impact on my child in various complicated ways, mainly due to the damage to the 2 primary areas of the brain and the deletion of chromosomes 15 and hyperplasia. She constantly feels and thinks about food, akin to the feeling of starvation, and she never has the feeling of satiety. This affects her daily life in an extreme way, as well as her tolerance level and temper control.
Over the years, you must have had a lot of experiences with different doctors. What is your impression?
Generally, we've been very fortunate not to have any bitter experiences with the diagnosis. However, later on, we realized that one doctor had suggested blood tests for her that were not actually required. That was the only bitter experience we had.
Actually, Prader-Willi syndrome is a complicated genetic condition that severely impacts several parts of the body in infancy. This condition is characterized by weak muscle tone, difficulties in feeding, poor growth, and delayed cognitive development. Patients develop an insatiable appetite right from childhood, resulting in chronic overeating called hyperphagia and obesity. Some patients with Prader-Willi syndrome, especially those with obesity, may also develop type 2 diabetes. Patients typically have mild to moderate intellectual impairment and cognitive disabilities. Behavioral problems are very common, such as stubbornness, temper outbursts, and compulsive behavior. Sleep abnormalities can also be seen, along with distinctive facial features such as almond-shaped eyes, triangular mouth, and a narrow forehead. Other physical characteristics include shortened height, small feet and hands, light-colored hair, and unusually fair skin. Both male and female patients may have underdeveloped genitals, delayed or incomplete puberty, and infertility.
Is there any chance of curing Prader-Willi syndrome, doctor?
Yes, but it's a lengthy process. Parents can enroll infants with Prader-Willi syndrome in early intervention programs. However, even if the diagnosis is delayed, treatments are available at any age. The types of treatment depend on the patient's symptoms. Some steps that can be taken include using feeding tubes or special formulas for patients with feeding difficulties. These methods ensure that the infant is fed completely and has proper growth. The healthcare provider will monitor weight, height, and body mass index periodically to ensure proper growth. By supervising daily food intake, parents can help prevent overeating behavior that starts from 2 to 4 years of age. This can minimize food hoarding, prevent rapid weight gain, and manage obesity. Growth hormone therapy can be performed to increase lean body mass, mobility, and height, reduce fat mass, and improve movement and flexibility from infancy through adulthood. Early initiation of growth hormone therapy may reduce or prevent behavioral difficulties. It can also improve speech, cognitive ability, abstract reasoning, and sleep quality. Additionally, it improves resting energy expenditure. Growth hormone therapy is usually started during infancy or immediately after the diagnosis and may continue into adulthood at a reduced dose. Patients who have trouble with their eye focus should be referred to a pediatric ophthalmologist if necessary. An orthopedist can evaluate and treat scoliosis, the curvature of the spine, which is common in Prader-Willi syndrome patients. Sleep disorders are also prevalent, and early treatment can improve sleep quality. Physical therapy is essential for children under 3 years of age to increase muscular strength and achieve developmental milestones. Behavioral therapy can help with emotional control, including anger, obsessive-compulsive behavior, and stubbornness, which are common challenges in patients with Prader-Willi syndrome. Medications such as serotonin reuptake inhibitors may reduce obsessive-compulsive behavior and help manage psychosis.
Thank you very much, doctor. That's been really useful.
Thank you, Mrs. Araceli.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
So today we have with us a guest who's going to talk on a topic that has all of us concerned, youth mental health. Before I introduce my highly respected guest, I just want to give you some statistics. First of all, 1 in 6 people diagnosed with a mental health condition are between the ages of 10 and 19. In fact, half of all mental health conditions start by age 14. but most cases are undetected and untreated, meaning that the consequences of not addressing mental health conditions extend to adulthood, impairing both physical and mental health and limiting opportunities to lead fulfilling lives as adults. In terms of the types of mental health conditions that many adolescents are diagnosed with globally, depression is one of the leading causes. This leads me to my final statistic, which is that suicide is the third leading cause of death in 15 to 19-year-olds. I repeat, the third leading cause. So now I'm pleased to welcome Dr. Stephen Jackson, a leading expert in adolescent mental health who works with the World Health Organization to design and implement programs related to this topic in countries around the world. Thank you so much for being here today to share with us information on this very important topic.
Thank you very much for the introduction and for making the case that adolescent mental health should be a topic that concerns all of us.
Oh yes, it is definitely a topic that I am passionate about. So can you tell us a bit about mental health determinants in adolescence?
Yes, of course. So anyone who has ever raised a teenager or even been around one knows that adolescence is a unique and challenging time. Multiple physical, emotional, and social changes can make adolescents vulnerable to mental health problems. Factors that contribute to stress during adolescence include a desire for greater autonomy, as well as pressure to conform with peers and the exploration of sexual identity.
I would imagine technology also plays a role.
Yes, access and use of technology play a role. The influence of the media and societal norms can make the difference between a teen's lived reality and their perceptions of the rest of the world hard for them to deal with. They're constantly comparing themselves to others. Other important determinants include home life and relationships with peers. Violence, such as harsh parenting and bullying, as well as socioeconomic problems, are recognized risks to mental health.
What about teens who are diagnosed early with a mental health condition? How does this affect them?
While early detection and treatment is always good, adolescents with mental health conditions are particularly vulnerable to social exclusion, discrimination, stigma, in addition to educational difficulties, risk-taking behaviors, and poor physical health.
So what can be done to support teens during this confusing period in their lives?
This period of life is crucial for developing and maintaining social and emotional habits important for well-being. These include adopting healthy sleep patterns, regular exercise, developing coping, problem-solving, and interpersonal skills, and learning to manage emotions. Emotional disorders commonly emerge during this period, such as depression and anxiety, but also excessive irritability, frustration, and anger. Oftentimes, people ignore these signs because they think they are normal teenage behavior.
So let's get to a little bit of hope and positivity. In addition to good habits, what can be done to promote and prevent mental health conditions from having a negative effect in the long run on teens' health and futures?
The first course of action is mental health promotion and prevention interventions that aim to strengthen individuals' capacity to regulate emotions, enhance alternatives to risk-taking behaviors, and build resilience into difficult situations. Supportive social environments and networks should also be promoted. These types of programs require a multi-level approach that involves many stakeholders, such as health or social care settings, schools, the community, among others.
So turning from prevention to those teens that have already been diagnosed with a mental health condition, what should be done in those situations?
As I mentioned earlier, early detection and treatment is crucial to address the needs of adolescents with mental health conditions. The goal is always to avoid institutionalization and over-medicalization and prioritize non-pharmacological approaches, considering the rights of the child.